In my practice, colonoscopy is always number one. Number two, colonoscopy. Number three, colonoscopy. But number four is actually stool-based testing, which has been very popular.
You're looking for blood in the stool.
No, we're actually looking for genetic alterations actually in your stool.
Of the stool?
Yes. A lot of it has to do with lifestyle. Like, for example, individuals that are beer drinkers, they're at higher risk.
Why is that?
The specific beer. Because statistically, that's what the data has actually shown. The problem with stool-based testing is, nationally, do you know where we are with colorectal cancer screening? We wanted 80% of the U.S. population at minimum to be screened. Mm-hmm. Do you know where we are today? We're roughly at 56%.
I had a patient, it was a young guy, and his wife said, he keeps vomiting, and he has abdominal pains, and he just keeps vomiting, can't keep anything down. They thought he had the flu. Turns out he had metastatic cancer. He was only 40 years old.
That for the most part, there really are no signs or symptoms. You're complaining more of a secondary issue and not really the primary issue, which is what makes it actually so challenging.
If you think we're trying to scare the heck out of you, we are. Welcome to Health Frontiers with Dr. Bob. I'm Dr. Bob, and I want to tell you that we're going to have a very interesting show today, and it's going to be all about colorectal screening for colorectal cancer, because March, believe it or not, is Colorectal Screening Month. I'm going to introduce our speaker today, Dr. Angel Lazo Jr. Let me give a little bit of introduction, Angel. Dr. Lazo is a board-certified internist, academic physician, and clinical investigator with more than 25 years of experience in resident education, programs, and program leadership, and the delivery of high-quality care to underserved and bilingual communities. You're very fluent in Spanish.
Absolutely.
Okay.
Definitivamente.
He's guided by a lifelong commitment to health equity. Dr. Lazo has consistently advanced educational excellence, clinical outcomes, and innovative research throughout his career. And this show is actually sponsored by Dr. Lazo's practice, his professional association. So I'd like to welcome Dr. Angel Lazo. Angel, it's good to have you here. And I know you schlepped over here from not too far, Jersey City, Union City, Correct. That area of New Jersey. So we're going to talk about colorectal cancer, screening awareness, and probably the disease itself. So first of all, why colorectal cancer screening? Why is it a major public health concern? Now, I would preface that by saying that we all know in medicine that young people today, in contradistinction to people over, say, 60, young people are getting more and more cancers of the bowel. Why is that?
Now, again, thank you so much for inviting me to talk. It's a real pleasure, Bob, Dr. Bob. Now, it's a major public health concern, because of the statistics that I'm actually going to share with you. Colorectal cancer is actually the second leading cause of cancer death, which is really, really sad, to be honest with you. And again, a lot of it really has to do with detection. But the statistics that are really the most fearful, and this is why it's a real public health concern, is because 76% of all colorectal cancer deaths occur basically in individuals that are late for screening or never been screened.
Wow. Which
is an amazing statistic.
And young people don't think that they need to be screened because they're young.
Correct.
And they generally don't get these things.
Correct.
Until now.
That's correct. And then 70% of the individuals that die of colorectal cancer, which in my opinion is probably the most preventable of all, are basically over the age of 65. So you can imagine, you follow your patient for decades, they get to that age of 65, only to find out a little bit later in life, that golden age is really no longer there,
right?
So to speak, once they get diagnosed with cancer.
Wow.
That basically tells us statistically that we roughly have about 54 million Americans as it stands today that are unscreened or late for screening, which is a huge, huge number.
Wow.
Now, one of the other sad statistics, which is what you were alluding to earlier, is that the leading cause of cancer death before the age of 50 is actually colorectal cancer. Take, for example, Vanderbeek, who was from Dawson's Creek. Got diagnosed at, I believe, 46, and unfortunately, he passed away this last year. He passed away. So it is the number one actually before the age of 50. But it is the most detectable by far.
Right. And it's an easy process, although, as we know, and is it more prevalent in females or males, or does it make a difference?
Honestly, in my experience, okay, once you mention the word cancer to a patient, and again, it doesn't really matter to them whether they're early, whether they're late, whether they're in remission. Once you mention cancer to a patient as a diagnosis, it's like they equate that actually to death, which is true for the most part, Colorectal cancer is actually no exception. Now if you look at the statistics for the 5-year survival rate, early detection, meaning stage 1 and 2, has a 91% survival rate, which is not bad. You know what I mean? But again, I remind my patients, that's great if you're in the 91%, but if you're in the 9%, that really doesn't do anything for you.
Exactly.
Now, again, as the disease progresses and you go more into regional disease, the overall 5-year survival rate is more like in the mid-75 range, 74, 73. But once you get the distal disease, metastatic disease, you're talking about maybe a survival rate in the teens, which is horrible. Yeah. Now, the part that's really hard to comprehend, and this is why I really enjoy inviting me to the show, is because how is it possible that the 5-year annual survival rate is 91%, which is great, but yet it's the second leading cause of cancer death? And the simple answer is that most individuals, 60% of them are already at either regional or distant disease. So early detection is really the name of the game when it comes actually to colorectal cancer.
Right.
Now, we are in a little bit of a different era now when it comes to colorectal cancer. And again, I want to discuss with you what are some of the barriers that we actually face, but more importantly, what are the options that we have?
Right.
Now, as a primary care physician, this is really in our wheelhouse. This is what we do all day, and this is basically one of the mainstays of what I do as a practice. Obviously, lung cancer is the number 1 cause of death, mostly related to smoking. But colorectal cancer is number 2, okay? And that really affects a lot of individuals. Right. I already told you the statistic of 54 million.
Right.
Of those 54 million, 37 million have never, ever been screened.
Now, there's a lot, to just interrupt you, there's a lot on TV about colorectal testing. In other words, taking your stool and looking for blood.
Correct.
Or the symptoms are never given to the public. Correct. But they are buying these little kits, et cetera.
Correct.
What do you think of that?
Well, again, I would say as a primary care physician, patients nowadays have options, including a blood test, which I'm going to talk a little bit about later.
Okay.
Because I think the blood test is a real game changer. Now, for early detection is actually a function of adherence, which is the key word that I really want the public to take home. Adherence. Listen to your doctor. You have options. In my practice, for example, option number 1 is always colonoscopy, and there's a reason for it. And the reason is that you get visualization, you can make a diagnosis, but you can also treat at the same time. So if you're getting your first-time colonoscopy, the gastroenterologist sees an advanced adenoma, it looks to be like cancerous. Obviously, he's going to clip it. He's going to take it out. He's going to send it for histology. And if it comes back positive for histology, you basically cured someone.
And for those who are out there in the public, an adenoma can be all different kinds of polyps. Correct. You've heard of polyps everywhere in your body, but polyps in the bowel are of particular importance. You want to just describe a few of the kinds of polyps that patients can have. Because I know they get a little sheet when they're done with their colonoscopy, and it says, you've had an adenoma, and they don't know what that is, or you've had a sessile or a fixed or a flat. What is that all about?
Yeah, that's a great question, Bob. Now, the ones that we really are concerned about are the ones that are called advanced adenomas. So polyps could be of a specific morphology, a specific size, and a specific histological type. Now, the ones that are actually a big warning sign that you're at risk for actually developing colorectal cancer are these so-called advanced adenomas. And they basically have 3 criteria that they include, and it could be any one of them. It's either by morphology, which is typically dysplastic.
Which means, morphology is the shape and size, and dysplastic is like cancerous looking. Go ahead.
Correct. And then histologically, the ones that are actually of concern that are the advanced adenomas are the ones that are either villous or villous tubular.
That's microscopic examination.
Yeah. And then second is the size. So if you have a polyp that's greater than 10 millimeters, that would be considered an advanced adenoma. And then again, if you have 3 polyps of any size or any type, that's also considered advanced adenoma. And these are the types of polyps, as to the common polyps, this is just adenomatosis. These are the ones that typically have more characteristics that are actually going to lead to colorectal cancer.
Wow.
Yeah.
That's so important for everybody to know. So the common, well, we're going to talk about testing in a minute,
Sure.
but the guidelines, I mean,
Right.
what in your range is the age range that people should consider having a colonoscopy? Now, people come in, as you and I know, for bone density, and we tell them, well, you're postmenopausal female, you're maybe 50 years old, you should have a bone density done. Or if you're a guy on steroids who's 30 years old, you should have a bone density done, because bone loss, we know, occurs in certain populations. But what about colorectal cancer? I mean, is there a population or populations or ethnicities or anything like that that can make somebody a little bit more aware of the fact that they need a colonoscopy?
Yeah, the main thing really goes by age and by your risk for colorectal cancer.
Right.
So now for individuals that are at average risk, okay, the age group is between 45 to 75. But again, that doesn't mean that if you're 84 and you're very active, you should not still be screened. And we're going to probably discuss some of the screening options.
Right.
But however, the main thing that I discuss with my patients is really who are the individuals that are actually at high risk, because that classification of individuals, it would actually be inappropriate to really screen them with anything other than a colonoscopy. And those individuals include anybody with inflammatory bowel disease, as you know, Crohn's and ulcerative colitis have an increased risk of colorectal cancer.
Very important to know, everybody out there.
And then again, if you have a first-degree relative, because you always ask your patients about their family tree, and I don't know why they always jump to the grandparents. It's like they want to forget their parents.
That's right.
But genetically, you're really going to follow what happens to your mom, what happens to your dad, what happens to your siblings, because you share pretty much the same DNA. So with the exception of the individuals that are actually at high risk for colorectal cancer, which are the first-degree relatives, individuals that have hereditary conditions, for example, that we already know, and then those that have inflammatory bowel, colonoscopy is always the preferred diagnostic screening.
How often should they be colonoscoped?
Now, again, that really depends on histologically when they get screened. But on average, it's anywhere from 3 to 7 years. The average is really about 5 years. Okay, but their gastroenterologist will let them know they're a higher risk population. And it's not uncommon that they get screened according to what they see on colonoscopy, even annually. But again, the important thing is to actually get screened, because in order to detect a cancer, and specifically colorectal cancer, that's actually a function of the sensitivity of the test and actually completing the test, which is adherence. Okay, that's the only way you're really actually going to detect.
Good. That's good to know. So those are the guidelines pretty much. And he did talk about ethnic groups. Is there any difference between, say, the African American population, the Arabic, the Hispanic, and the Caucasian populations? Is there any higher incidence in any of those groups?
In some of these groups, for example, like the African Americans, you will see a little bit early. It's almost something very similar to what we see actually with prostate cancer.
Right.
But however, a lot of it has to do with lifestyle, to be honest with you. A lot of it has to do with lifestyle. Like, for example, individuals that are beer drinkers, they're at higher risk.
Why is that?
A specific beer. Because statistically, that's what the data has actually shown.
I can talk about epigenetics and environmental influences like beer on the occurrence of cancer.
Yeah, alcohol has an increase, but specifically beer. Beer, smoking. So those lifestyle modifications actually really do make a difference. And again, we talked about advanced adenomas, and those are the ones that are actually going to put you at risk for actually developing colorectal cancer. But another term that's actually very commonly used, especially when we talk about options for patients for colorectal cancer screening, is actually advanced neoplasia. Now, advanced neoplasia basically means you either have an advanced adenoma or you have colorectal cancer. So that's kind of like a mixed term, like a general term. Whereas when you tell someone you have colorectal cancer, that means you specifically have cancer in the colon.
Right. Now, if I go and I get colonoscoped, and this is for the public out there watching, and the doctor says, you've got 3 or 4 polyps, I just removed them. Does that mean that I have to be re-colonoscoped in about a year? Can I wait 2 years, or is it appropriate to wait 5 years if polyps have been seen in my bowel?
Yeah, if you have more than 3 polyps, actually, then that falls automatically under the category of advanced neoplasia. Now, it doesn't necessarily mean that you have to, But at minimum, you should do stool-based testing or at least blood testing within 3 years.
And when you say stool-based testing, you're looking for blood in the stool.
No, we're actually looking for genetic genomic alterations actually in your stool.
Of the stool?
Yes. Like, for example, in my practice, colonoscopy is always number one.
Mm-hmm.
Number two, colonoscopy. Number three, colonoscopy.
Right.
But number four, and again, this is what we've had to date pretty much now, is actually stool-based testing, which has been very popular. The problem with stool-based testing is, nationally, do you know where we are with colorectal cancer screening? I mean, we set the bar a very long time ago, a couple decades ago, that we wanted 80% of the U.S. population at minimum to be screened.
Mm-hmm.
Do you know where we are today? We're roughly at 56%.
Wow.
And that's where the 54 million come from. Yeah. Because you and I talk to 100% of our patients in reference to this.
Right.
But we're basically right now at 58%.
Wow.
Now, my fourth choice, because my first three are colonoscopy, because again, an educated consumer is always your best customer.
Right.
And again, you go by sensitivity and likely to pick up. Cologuard is typically the one that I go to.
Right.
Okay, and it's the one that we've been going to actually for a long time.
Mm-hmm.
Now we have Cologuard and Cologuard Plus, which gives you roughly about up to 95%, 92 to 95% respectively of sensitivity. But the problem is that as physicians and clinicians, sometimes we put way too much weight actually on these, how sensitive a test is and so on and so forth.
Right.
Do you know what the sensitivity is of a test that is 100% sensitive, but yet nobody does? Zero adherence? The answer is zero. You're going to detect nothing. So as clinicians, we use sensitivity and specificity.
Yep.
They have specific meanings, but sometimes we get a little bit hung up on that. And part of the problem with a lot of these stool-based tests, which is Cologuard, Cologuard Plus, FIT test, and fecal cold blood testing, is adherence. Mm-hmm. The adherence rate actually for Cologuard is anywhere between 65 and 71%. Very sensitive test. But however, if you're in that 30% that you don't do it, which happens in my practice, I can't tell you how many times I have the discussion with the patient, colonoscopy. All right, I'm going to send you a Cologuard box. I send it out in November, to the patient. They come and follow up with me next month about blood work or whatever. I look on my chart, in the Epic, and I see that it still hasn't been active. They haven't done it.
Wow.
And I'm like, John, what happened? I sent you the box. He's like, well, I thought it was a gift and I put it under the tree, even though I spent 25 minutes speaking with them about what they were going to receive and to do it. The bottom line, part of the reason that we actually been failing is because a lot of these so-called non-invasive testing, which has been up to recent, just stool-based, has a very poor adherence. Right. Stool-based testing ranges anywhere from 28% to 28 to 71%.
Oh, that's amazing.
And that's part of the reason we're at 58. I mean, we're in a new era now.
Yeah.
So it's a little bit different now.
So to sum it up, we have ways other than colonoscopy, which I highly recommend and which Dr. Lazo recommends, but we need to do it in younger people, particularly if you have symptoms. What kind of symptoms, other than blood in the stool, if one looks for blood in the stool, but people do not do that as a rule. And it's not bright red blood necessarily that's in the stool, unless you have inflammatory bowel disease.
Correct.
It could be just maroon-colored, wine-like, Merlot-colored blood. Yeah. What do you do? I mean, if you have symptoms, and what are the symptoms like? I had a patient I just want to mention. Right. It was a young guy, and his wife said, he keeps vomiting, and he has abdominal pains, and he just keeps vomiting, can't keep anything down. They thought he had the flu. Turns out he had metastatic cancer. He was only 40 years old.
Absolutely.
It's unbelievable.
Yeah. And again, this is part of the problem with cancer. Yeah. That for the most part, there really are no signs or symptoms. Right. In fact, as a primary care physician, a lot of my patients tell me that, well, doc, why do you want to screen me? I'm kind of young. I don't have any signs or symptoms. I don't have any symptoms. But again, that's typically the majority of the individuals. But as you alluded to, some of the signs are blood in your stool, whether it's in your stool or in the toilet. Right. Dark colored stool, very sticky. Right. And or if you start to, out of the blue, have pencil stools. Because by the time you start to have the manifestations of obstruction and or other signs or symptoms, you're already talking about advanced disease for the most part. So you're complaining more of a secondary issue and not really the primary issue, which is what makes it actually so challenging.
And if you think we're trying to scare the heck out of you, we are, because you should go and get your colonoscopy. You should get examined by a fellow like Dr. Lazo to really save your life. And I mean, it's going to save your life. So let's talk. We talked about colorectal screening modalities and options. I think we've talked about that. What about the pitfalls of colorectal cancer screening? Everybody worries about that. Well, first of all, I have to tell you, my patients tell me, I don't want to get a colonoscopy. I have to drink that stuff, gallons of that stuff called Golightly.
Right.
And things have changed a little bit. That's not exactly what people have to do anymore to get to clear their bowel.
Yeah. Yeah. The obstacles actually that we have are actually twofold, because it's really part of the physician, but more importantly, it's actually the patient. Our role, and I specifically as a primary care physician, like to offer patients the data and options. Okay, colonoscopy will always be the first one. But here's where the problem starts. Unfortunately, not everybody gets a colonoscopy that's basically covered. There's different fees that are involved, whether it's through anesthesia or the surgery site fee, et cetera, et cetera. But again, for most blue-collar Americans, it's a hard sell. Because if first off, you got to do a colonoscopy, you typically have to go see the gastroenterologist first.
Right.
That's a higher copay, as you know, Dr. Bob.
That's exactly right.
It's a higher copay, okay? But it doesn't end there. Then the real problem is that they have to actually take a day off of work. And for a lot of Americans, you take a day off of work and you don't get paid. Okay? And that's a big problem.
Those are all big issues.
The prep is an issue. Obviously, the prep is kind of an issue for a lot of patients. It's a little bit easier now because you don't have to necessarily do the whole gallon. But again, if you're dealing with an elderly individual that's got complex diseases, renal failure, heart failure, even if you're going to put them on the conscious sedation for a colonoscopy, it's a little bit risky for them sometimes. I know the patients sometimes will tell me, but what are the risks involved? The gastroenterologist will go over it. Okay, and there's perforation that's a risk, but again, it's a procedure, and that's understood. Rarely happens, and it's definitely not an excuse.
They rarely do happen. So it's a very safe thing. For those of you out there who are concerned and who are thinking about this. And regardless of this, my patients come to me with dreadful diseases, and they say, well, the copay is $35. Well, $35 in some parts of the country is a cab ride. And is it worth it for your health to ignore, even if you have to borrow the $35, go and get it done?
Absolutely. And then the second options are actually stool-based testing. Okay, which are, some of them are exceptionally accurate, for example, like Cologuard and Cologuard Plus. But the problem is the adherence. 3 out of 4 individuals that have actually done a stool-based testing will not do it again. Now, what do I do in my practice? When I talk to John and he already did the stool and he goes, Doc, I'm not going fishing for stool anymore. What do you got? Well, what do you think I tell John? I said, John, this is a perfect time for a colonoscopy.
Right.
Okay.
Exactly.
Now, again, if he denied it the first time, there's a good chance he's going to deny it again. And do you know what the adherence rate actually is for colonoscopy?
No, that was my next question.
It's 56% nationwide.
The adherence rate.
It's 50. It's not where it really should be.
Wow.
So most individuals actually don't get it. And I see it in my practice, you know what I mean, where I schedule a colonoscopy for an individual only to find out when he comes back 2 weeks later, he didn't do it the week before because his brother-in-law came in out of town from Canada, wanted to see it, got tickets for the hockey game at the Garden, and he skipped the colonoscopy.
And that was the end of that.
And that was the end of that. But now we're in a different era, and this is really why I'm kind of excited about colorectal cancer screening.
Right.
Because I personally really want to make the state of New Jersey the first one in the union to actually get to the 80%.
That'd be great.
And now the patients have an incredible option, and it's not just the patients, the docs also have an incredible option, which is now a blood-based testing.
Right.
So we actually do have a blood-based testing now, which actually has an incredible adherence.
Right.
Because again, you speak to your patient about colorectal cancer, they say, yes, that's acceptance. But then to actually complete it, that's the problem. And this is the problem that we have even with colonoscopies with them. Because remember, most individuals, when they go for colorectal cancer screening and you refer them to the gastroenterologist, it's not like they schedule it like in a week or two.
Right.
It takes sometimes months. Yeah. And this is part of why they fall off the wagon, so to speak, because then they forget about it or they go on vacation or whatever. But with blood-based testing, it's kind of like a here and now test. So it's a simple blood test. It doesn't really require any spinning, any separation of serum. And basically, all tumors basically shed DNA. And then the DNA actually gets digested into fragments, hence the term fragmentomics. And then we're able to pick up these genomic and epigenomic alterations. And that's why the blood test is called a cell-free DNA testing, because it picks up these genetic, for example, in colorectal cancer, they're CRAS mutations. So you're actually able to detect that actually in blood.
And that's widely available? I did not know that.
Well, this is part of the problem. And the answer is yes and no. Okay, it should be an option for every single patient. But every single primary care physician really needs to have that conversation with the patient. Yeah. But it always should start with the colonoscopy. I mean, I can't say it enough. Colonoscopy is the gold standard. Now, if you hit a wall with the colonoscopy and you hit a wall like you always have with stool, not just with them saying yes, but never getting it completed. Once you mention a blood-based testing for patients, it's widely accepted. That's why it's a here and now test. And the statistics are within the parameters of every single stool-based testing that we basically have, as far as sensitivity, advanced neoplasia specificity. Now, one of the things that I really wanted to tell the public, and especially my colleagues, okay, we put a lot of emphasis on sensitivity and specificity. But positive predictive value, negative predictive values are statistically and clinically a little bit more relevant. Sensitivity and specificity basically looks back. Whereas positive predictive value, negative predictive value take the prevalence of disease into account. And that's really where you fall statistically.
Okay, so that's a little bit complicated for our patient audience to quite understand. But remember now, we're hearing that there is a blood-based test for colorectal cancer, which is really incredible. People don't like to touch their stool or anybody else's stool for that matter. So that's where the problem lies there. But remember, just to digress, I talk about the pandemic and finding viral DNA in sewage all of the time. And that's how we monitor how much virus there is, say, in the city of New York by looking at the sewage that comes out of the city of New York. But now we're coming into a blood test that can actually measure. And how available is this blood test? And, do most doctors have it, or do they know what it is?
Yeah, great question. Now, I recently started to see the commercials for the blood test. It's called Shield, which is actually produced by Garden Health, which is one of the leading oncology blood testing companies. So you're going to be seeing the Shield testing actually now on commercials. Very, very widely accepted with patients. Now, I, as a healthcare professional, I hit a wall when it comes to, because of the specific institution, for example, that I work for, doesn't actually allow me to offer that as an option. Okay, so that's obstacle number one. The institution that you work with may not even be able to accept this as a test yet. I don't know why, because the National Comprehensive Cancer Network, which are the 33 leading cancer centers in the country, Sloan Kettering, Moffitt, et cetera, they have adopted this and actually gave this a category 2A, same as stool-based testing. So it's an amazing option, but unfortunately, some of the institutions are not on board yet. I find it highly disturbing, to be honest with you. I hope the state actually really does something like that, because I, as a primary care physician, should be able to offer my patients all options. Now, because it's a relatively new test, they are covered by Medicare now, and they're obviously seeking, it's like any new drug that comes out, commercial acceptance and so on and so forth. So that's the second obstacle. But that's going to be a short obstacle. The bigger obstacle for me now is getting my institution to recognize, we're not meeting the parameters. We can save millions of lives by offering this as an additional option. But this does not belittle in any way, shape, or form a blood test. Colorectal cancer screening should always be done by colonoscopy, and there are other options, not just stool-based testing now.
That's extraordinarily important to know. Those of you out there who are watching, this is a very important topic, and it's something that you should really listen to, and subscribe to our show, by the way. You can do that with the bottom of the screen and follow us. So you should watch this show over and over again if you have any concerns about colorectal cancer, which I'm sure everybody that watches this does. It affects all of us. It affects every person on the planet. So where are we as a nation now with regard to colorectal screening? Probably you already talked about
very
the
poor.
Millions of
very
people who are not screened.
Very poor. And that's why moving forward, we're actually in a new era, because we have a significant new player in the game, which is really what patients prefer. which is blood-based testing,
right?
Which is here and now.
That's
and the
important.
adherence rate is actually phenomenal.
Right.
So I think that this new option that we actually have now, which is that Shield cell-free DNA blood testing, is actually going to get us closer to that 80% mark. And if anything, it'll bring us well above.
Right.
I'm on a mission to make New Jersey the first state to actually reach 80. Do you know where we are in New Jersey?
I don't have a clue.
62%.
62%.
You want to know who's the worst?
Who?
California.
Does that surprise
at
us?
53%. But let's talk about who's the best.
Who's the best?
Actually, it's Massachusetts and the District of Columbia. They're at 70.
All the politicians are getting their colonoscopies done.
So I challenge all of my primary care physicians. I challenge your state. New Jersey will be number one. So
I have a lot of jokes that can go with the politicians and DCB, first in the nation. Yeah. Anyhow, can we discuss advanced adenomas and advanced neoplasia?
Yeah.
And is supposing you have a metastatic colon cancer. So I know a couple of patients that have had colon cancers, and the doctors are saying, well, we'll do chemotherapy for starters to shrink the tumor, and then I guess have it removed surgically.
Yep. Now, advanced adenomas, the difference between an advanced adenoma and advanced neoplasia is that by definition, advanced neoplasia, which again, for the general public, it doesn't mean too much. But advanced neoplasia means you either have advanced adenoma or colorectal cancer. Like, for example, Cologuard is actually indicated for advanced neoplasia. So that means if you have advanced adenomas and or colorectal cancer, that's the detection that you're seeking. But again, this is stool-based. And 3 out of 4 individuals at stool-basing will not do it again. Advanced adenoma is actually an important characterization. And again, that's by histology, morphology, and size.
Right.
So once you meet that criteria that you have greater than 10 millimeters, that's an advanced adenoma. Histologically, if it's villous or villous tubular, that's an advanced adenoma. These are the ones that are more likely to progress to colorectal cancer as compared to just a regular adenomatous polyp. Right. And again, if you're characteristically metaplastic, again, you're likely to progress. This is why, for example, and this to me is sometimes a little bit disturbing, but again, I can't ignore the data either.
Right.
Where a patient of mine will be 60 years old, they'll get a colonoscopy, and the GI doc will say, you're good for 10 years. And that makes me cringe, to be honest with you.
Right.
Okay. Right. But however, the data does show that if you do not have polyps in your colon, statistically, the chances within a 10-year period that you're actually going to develop cancer is exceptionally low. Okay. But it doesn't equal 0. And that's where I have a problem with it.
Okay.
So hopefully in the future we'll change that.
Very good point.
Absolutely.
Absolutely. Yeah. Now, there's a lot of discussion, and this is going to be an interesting discussion about the microbiome. Everybody talks about the microbiome. Yeah. And just for you out there, the audience, the microbiome, which is extraordinary, refers to organisms in your bowel, trillions, by the way, more than the population of the city of New York and the 5 boroughs. So you have a lot of bacteria, viruses, and parasites within you. Also in your lung, on your skin, etc. But the ones in the bowel are particularly important because we refer to the bowel and the brain as being almost 2 synonymous organs. Correct. So how does this microbiome? Everybody's on a probiotic. Everybody is on. Last night, my wife gave me a teaspoonful of specific kind of olive oil, very expensive, by the way, virgin olive oil, to take it. Right. And I'm saying, gosh, people drinking wheatgrass, beet juice, all kinds of stuff. Yeah. What does that do to the bowel flora? And does that help with the prognosis of bowel cancer?
It's a great question, Dr. Bob. And the answer is yes, it actually does make a difference. Okay. So for example, you will see, and again, everything is about lifestyle modification. When the individuals that actually are more likely to eat processed food of any kind, but especially meats, the meats are the ones that actually really are the problem because exactly as you alluded to, part of it has to do with the microbiome that you develop if you're a big meat eater. It's very different. Your bacteria in your gut is very different than if you say, for example, you're a vegetarian or a vegan. Right. And that's why it makes such a tremendous difference.
Absolutely.
So, and again, it has to do with the microbiome as well.
And we hear about baby aspirin
right.
or regular aspirin or folic acid, which is
Right.
another vitamin that people are taking
Right.
routinely,
Right.
does that have any effect on the occurrence,
Right.
prognosis, future of an individual, be
Right.
they an elderly person, say of 80 years of age?
Well, having practiced medicine for 28 years, and I've been in
Yeah.
academia. Okay, this kind of drives me crazy, to be honest with you.
Okay.
Because today aspirin is bad, but yesterday it was good. The week before it was bad. A
Right,
year
right.
before, so they keep wavering on whether it is or is not.
Right.
But this is my own personal perspective of what I do in practice.
Mhm.
Okay, my understanding is that actually aspirin really does inhibit adenomas, those polyps.
Mm-hmm.
Typically, individuals don't develop colon cancer directly from the wall. It typically is a polyp that becomes cancerous, and because they're embedded into the matrix of the colon wall,
Right.
they progress actually to colon cancer.
Mm-hmm.
Okay, so, but aspirin has other benefits that are cardiovascular, and especially for women, for example, it decreases leukemia by like 50%. So if I can even make a little bit of difference in colorectal cancer by not developing that one polyp, so to speak, then I'm on board.
Right.
What I tell my patients, and again, the fear of individuals taking aspirin unnecessarily is GI bleeding, which is a serious concern, obviously.
Mm-hmm.
But in 28 years, I can't even remember one death certificate that I ever signed from someone that bled to death from an aspirin.
Oh, I agree with you.
Yeah.
I signed a lot of death certificates in my day and never saw that either.
Never saw that either. So
No,
it's a great question. I favor aspirin to err on the
Yeah,
side of
yeah.
caution.
And
so to speak.
folic acid is another
As well.
big one.
Absolutely.
And other drugs that people take, anti-inflammatory medications, for
Correct.
example.
Right.
All of these things have an effect on our bowels, especially our large bowels.
Correct.
And so eventually there's going to be some sort of anagram or algorithm
Right.
that will prevent or tell us that it prevents colon cancer,
Right.
which again is really occurring in younger and younger people today,
Yeah.
and is a big concern.
Yeah.
So this show is really, really important, especially to younger people.
Absolutely.
So you already discussed the sensitivity and specificity, the positive predictive value of a screening test.
Right.
And so the best screening test, would you say, of course, the breast screening test is the colonoscopy,
colonoscopy.
1, 2, and 3.
Yeah.
But then after that, the blood test, because people are not prone to taking their
Correct.
stool. I
Yes.
remember I used to give these cards to patients, and I'm sure you out there, if you're a patient, got a stool card from your doctor, put the stool
Right.
on there so we could test for blood. This is years ago,
Yeah.
probably gone now. But years ago, I'm talking 30, 40 years ago, where people went home and they never mailed them back so we could test them for blood. But that's gone by the wayside. That's so nonspecific.
Yeah.
And the predictive value of that's probably very low because people have hemorrhoids, and hemorrhoids will make the test positive.
Right.
So this is a new era in colorectal cancer screening.
Right.
And you're right. You want to get us to be the number one state.
Yeah.
And Massachusetts is number one. And the lowest is California.
And the lowest is California.
It's probably because of all the characters in California. Okay.
But it is a wonderful time to practice medicine,
Yes.
because again, as you know, Dr. Bob, all of our diseases are basically due to gene expression, whether it's faulty DNA and then faulty signaling and so on and so forth. And we're having incredible advances in, digital PCR and genomic sequencing and so on and so forth.
Yeah.
All of those signal molecules are in the bloodstream. Okay, it's just a matter of finding them.
Yep.
This company came out with the first cell-free DNA blood test, to pick up these genomic and epigenomic alterations.
Mm-hmm.
It is the wave of the future. It's actually only going to get better.
Yes.
The sad part is, however, that just like Cologuard, the blood test is indicated every 1 to 3 years, but the payers only pay every 3 years.
Right.
So if you're going to do it every year, unfortunately, you would have to go out of pocket. Same thing as Cologuard.
Yeah, we're referring to insurance companies when we're talking payers.
Yeah, so I'm hoping that in the near future, this will be a routine annual physical examination blood test that you can offer to your patients. And again, that will never, ever replace colonoscopy. We're always going to talk to you. So if you're a patient, we're always going to talk to you about
Out of curiosity, how much does this blood test cost?
Roughly, I believe the reimbursement currently right now is about $1,450.
$1,450 to preserve your life.
Yeah.
That's pretty cheap when you think about it.
Yeah.
Pretty cheap because remember, health is wealth. I always talk about that on this show.
Yeah. And you can't buy health.
You can't buy health.
But you can screen.
You can have all the money in the world and still get colorectal cancer.
Absolutely.
So it's important for you to open your wallet and really go forward.
Yeah.
So we've covered a lot. Is there anything else that you'd like to cover in this area? This is a very important area.
Yeah. Well, I want to speak specifically to the patients, you know what I mean? Because part of the responsibility really is primary care, for example. So just make sure that you ask these questions of the patient. Listen to all the options. Don't be quick to say, oh, yes, I'm going to do a blood test. Listen to the data, listen to the why. But again, you got to get screened. There are 54 million Americans that are walking around right now with colorectal cancer. And 37 million of those individuals have never, ever been screened. And now there's a simple option for you if you've really been reluctant to not do what the standard that has been failing us. And detection is, again, the cancer. To my patient time, you got cancers that you can cure, and then there are cancers that we try to modify your lifestyle and modify your quality of life, but eventually it will get you.
Right.
Colorectal cancer is one of those cancers that actually could be treated if detected early. Right. And the statistics show very good survival.
Really? That's
with
true.
Early detection.
That's very true. And it doesn't mean that you're going to have a colectomy and wear a bag, which is what everybody's worried about.
Absolutely not.
You get detected early enough and you will survive. With the tumor or the polyps being removed.
Correct.
So this is a very, very important program to remember. It's an important show to watch. And you can have your friends and family watch this show on YouTube. And again, subscribe and become one of our followers because we have many, many very interesting programs that mean that your health, which is your wealth, will continue in a good way.
Yeah.
Okay.
Well, thank you, Bob.
I want to thank you for coming on today. Any last words?
Yeah, last words. Again, when you do a screening test and it comes back positive, okay, like a stool base or even the blood test, it's inappropriate to order another screening test. Once you get a screening test at stool base or blood test positive, typically your colonoscopy will always 100% be indicated and typically covered by insurance, so it doesn't become an issue.
Right.
But once you've had a positive screening test, then you really do need to do the colonoscopy.
Right. So. And if you don't have health insurance, you need to have this anyhow. There are a lot of self-payers, a lot of patients who can't afford things. Believe me, we'll find a way to get you tested and treated. So don't, a famous word, don't go away without being screened if you have no health insurance. You're a student, for example, who's got bloody stools, and you're in college and you can't afford probably your daily food, your meal allotment. Just get it done, and we'll worry about the cost later.
Yeah, and there are different charity clinics throughout the state, federally qualified health centers.
Exactly.
So don't use the money as the excuse or no insurance. Seek help and you will find it.
Yes, very good. Okay, Dr. Lazo, why don't you tell us a little bit more about your practice?
Excellent. So I'm a primary care physician, practicing actually here in Hudson County. Now, primary care physicians are basically doctors that have had a minimum of three years of internal medicine training and have a focus on primary prevention and disease. I, in particular, a little bit of a different breed because I consider myself to be more of a cardiovascular, kidney, metabolic specialist. Now, I'm very much into pretty much the molecular basis of disease. And as you know, Dr. Bob, if you have a pretty good understanding of molecular basis of disease, then you have a much better comprehensive understanding of the molecular basis of treatment. So, but I'm able to bridge what happens at a cellular level to the clinical practice.
Yes.
So I consider myself a little bit more of a clinician. I take basically all insurances as part of the system that I'm with now. I've done that my whole professional career. I basically have dedicated my career really to the underserved. This is where the health equity comes from, which is a new term now, but I've been doing this for 28 years, Whether you're the guy under the bridge or you're the executive from Goldman Sachs, you get treated the same because guess what? You present with the same conditions.
Exactly.
And you have the same problems for the most part.
Exactly. And that's so important to understand that medicine is the great equalizer. You can be an Ayatollah in Iran or you can be the president of the United States. You have the same risk of developing an adenomatous polyp in your colon.
Correct.
And that's really great. It's good to hear that because physicians often forget that they are really at the forefront of saving lives. That's the most important thing we do, saving lives.
And as a primary care physician, again, I go by prevalence of disease in my practice.
Yes.
And this is why I have a stronger background actually in cardiovascular disease, because that's the number one killer.
Right.
So the number one killer in the country and globally is actually cardiovascular disease. Second is cancer.
Right.
But I chose the secondary cause of cancer as the number one mission in my practice because that's the one that I can really do something about. Someone that smoked, 15 years ago and quit 5 years ago now becomes my new patient. There's nothing I can do to help them.
Right.
So I've dedicated mostly to underserved and go by prevalence of disease, which is cardiovascular. And I'm a metabolic specialist, and I'm also a specialist in COVID, as you know. So actually I have a nice publication during the pandemic.
Very interesting.
Using extracellular vesicles for ARDS.
Yes, I remember that.
Yeah. So
yes. Very good. Congratulations on that.
Yeah.
So I want to thank you all for watching us and for listening to us. And again, subscribe to our shows, Health Frontiers with Dr. Bob. I want to thank you all for participating and paying attention. And we'll see you at our next show. Thank you. And thank you, Dr. Lazo, for a wonderful words of wisdom today, which is probably going to save a lot of lives.
Thank you, Dr. Bob. And yes, let's go save some lives.
Save lives. Thank you. Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.